November 5th, and a lot has happened in just a very short period of time. So again, I really appreciate everyone joining. We've got some really exciting things to talk about, and again, the goal is to make this as interactive as possible. I know that for several of you, you were here for the first meeting. Many of you, this is probably your first time. So what we're going to do from the agenda side is I think it would be great to start with just introductions. We have folks here in the room. We have several people that are on virtually as well, and we may not be able to hear them speak. But why don't we just start maybe on this side with introductions? If you can just introduce yourself and go around the room.
Sure, I'm Shauna Huber. I'm the owner of Virtual Life Care Planning, which is a local care coordination, case management, life care planning business.
I'm Trudy Overby, College of Health Sciences and Professions here in Dublin.
I'm Doug Boland, Chair of the Department of Social and Public Health down in Athens, Ohio.
Gary Claybone, I'm the Director of the School of Rehab and Communication Sciences and College of Health Sciences and Professions.
And I'm Leslie Kuhnfair with College of Health Sciences and Professions in Dublin.
I'm Mark Ridenour of the Ridenour Group, and I'm here representing the Ohio Optometric Association.
I'm Ernie Boyd. I'm with the Ohio Pharmacists Association.
Robert Kane, I'm the Associate Dean for Graduate Medical Education.
Maria Umberto, Associate Chief of Staff for Education and Research at the Chillicothe VA.
Lydia Sheehan from the Heritage College of Osteopathic Medicine.
Ann Shealy, Lower Lights Christian Health Center.
Tim Perry, Chief Quality and Compliance Officer at Insight.
I'm Deb Misek. I'm the Chief of Staff at the Chillicothe VA here with the Resurrect.
And I'm Christine Gordon, Medicine Specialist and founder of Resurrect Life Foundation.
I'm Kevin Burke. I'm the Vice President of Strategy with Medical Advantage Group. We're actually owned by the doctor company.
I'm Randy Leidy, Dean of the College of Health Sciences and Professions at OU.
Steve Golding, Vice President of Finance Administration, OU.
James Francis, Chief Data Officer for Insight Health.
Francesca Wagner, I'm the Business Development Coordinator for Insight Health.
Erica Moncrief, Vice President for Provider Solutions for Insight Health.
I'm Chris McGill. I'm presenting, that's why I'm sitting here. Like, I'm the Economic Development Director for Ice Miller LLP.
Great. And I'm not sure if, Christine, can you try one more time? If we can't hear you, then we'll just move on.
Yeah, I'm here. Can you hear me?
You want to try to introduce yourself? The speaker system's working?
Can you hear me?
Barely hear.
I can barely hear.
Can you hear me?
Very, very.
Yeah.
I can hear something too.
Okay.
I used the dial-in because the computer, you couldn't hear me.
We have a hard time here, but maybe we can work through it in the next few minutes. But again, I apologize for starting late. I know that Chrisanne has to leave a little early, so I'm going to try to move forward with this and try to get us back on schedule if we can. Again, this is the second meeting. Just to recap where we started and why we're here and what this is all about. Obviously, today, there's some major transformations happening that will significantly impact healthcare forever, right? And when you look at what's happening, there's this major transformation from this old model of having a fragmented care, pay for service, to now everything is moving towards a patient-centered, coordinated care, pay for value type model. Okay, and I'm sure that this isn't new to anybody. It's very, very significant. So a lot of planning, a lot of discussions have been going forever, or for a while now, to kind of provide all the motivation, all the incentives to get over to the value-based care. And with this transformation, there's a lot of questions, right? So first off is that the requirements now are new requirements. So how organizations, how healthcare constituents conducted business yesterday is going to be different than how they need to conduct business tomorrow. Everyone has to re-engineer their business to basically survive and thrive in this new normal of healthcare. Okay, and with that, with the new requirements, there's challenges associated with how do each individual stakeholders across the care continuum manage to these new requirements. And some of the challenges is that there's some obvious gaps, right? To truly get to value-based care, there's several gaps, two of the predominant gaps. The first one is there's a known gap in the technology today, right? So as several folks have made investments in electronic medical record systems, they've participated in health information exchanges, or they're planning to. Many of these solutions were designed to solve a different problem than value-based care, right? So the EMRs were designed to basically store and retrieve information within the four walls of a clinic or a doctor's office. They weren't designed to easily share information across providers, right? And now with value-based care, obviously the whole key is around interoperability. And that interoperability can be defined a lot of different ways. And many individuals think that see interoperability as, I've got one EMR system, you've got another one, let's make it so we can talk, share information. That's certainly an example of interoperability. But when you look at value-based care, that's, again, just one example. To truly operationalize value-based care, in addition to being able to get the different EMR systems to share information, the goal is now I'm a high-risk patient and I've got a care team. And some of those members on my care team are very sophisticated, they have a sophisticated EMR. Some of them are dietitians and chiropractors, they don't have an EMR system. So when you talk about interoperability, not only are we talking about system to system, but you're talking about system to no system, right? Everyone basically has a piece of information on a patient that's common. And the goal now is how can we bring all this information together so collectively we understand the true needs and risks for our common patient. And collectively we can work collaboratively to better coordinate care with the goal of improving patient outcomes. Right, so everything with value-based care is focused on improving the quality, improving the cost, improving the satisfaction. To do that, again, you have to deal with interoperability between systems and different levels of sophistication. The other issue that's important is to truly understand the true needs of that patient. You have to look beyond just the traditional clinical sets of data, right? So the behavioral, the environmental, the social indicators, it's equally important to get all that together. So that's the key for value-based care, and obviously that's the opportunity and the challenge here. And again, there's been a lot of buzzwords, right? So population management and accountable care organizations and patient-centered medical home and chronic care management and you name it. There's a lot of terms that are floating around. The question is, what does it mean? Where does it fit? And how do we get from where we are today to take all of these techniques and technologies and initiatives so that they work, right? So they actually work and move forward. And how do we do this where we can learn from experience? So that's really the goal for value-based care, right? So again, there's a known, one of the gaps is the gap in technology. The other gap is the needed collaboration, right? So for value-based care, collaboration is essential, right? It doesn't make sense to have a payer spend a lot of time and effort to basically figure out what their care coordination system is, and a doctor and a provider and an FQHC and everyone else will figure out what their care coordination system is. By definition, again, it's a system that allows us all to share common information on a common patient. Right, so to do that, there has to be collaboration. There has to be needed collaboration. So the Value-Based Care Center of Excellence, the goal is to promote collaboration. Okay, so the goal here with the vision is to create a shared facility that provides leadership, provides best practices, research, support, training, and proven demonstrable technologies and interoperable systems for advancing value-based care. That's the goal. Okay, so you're not going to get there by making decisions in isolation. We have to have that collaboration, and that's really the cornerstone for the Value-Based Care Center of Excellence. So when you look at the Value-Based Care Center of Excellence, again, there's collaboration that has to take place, and it has to take place across everyone that's in the space, whether it's government, right? So here in Ohio with Ohio Health Transformation, West Virginia with the efforts they're doing across the country with the health transformation initiatives. the payers, the hospitals, the primary care physicians, the FQHCs, the non-physician providers. Okay, all of those stakeholders have to figure out how they're going to share and communicate and collaborate. Anyone that supports those those constituents, whether it's the EMR vendors, HIT vendors, the labs, the pharmacies, everyone has a role to play. So this collaboration is essential. Okay, what has to be solved? Again, there's been a lot of design model grants. Here in Ohio, we spent a lot of time and money taking the state innovation model grant and figuring out from a design perspective, what's the critical components that we have to solve together. And they're outlined here. So everything from care coordination, patient engagement, privacy, security, interoperability of systems, identifying the health determinants. Everyone knows that these are the issues that have to be addressed. Okay, the Center of Excellence, the goal is to create a platform to address this and truly to make things happen very quickly through collaboration versus through isolation. So the Value-Based Care Center of Excellence, these are the core tenets that all of these projects will have to touch and address each of these areas and each of these constituents. Okay, so it sounds like a very big and complex and sometimes overwhelming issue and task. I'll tell you that this, as complex and as difficult as this task is, we know it can be achieved, right? So this model that we're leveraging here for advancing value-based care is the exact same model that we kind of work through dealing with national security. And again, my background is we spent a lot of time over the last 10 years helping to solve the same issues and the same problems that we're witnessing today in healthcare for national security purposes. So everything that we're talking about here isn't new. Okay, it's applying proven technologies, proven techniques to basically help advance the same challenges that we're seeing here in healthcare. Okay, and establishing these centers of excellence are absolutely critical to advancing the cause. Okay, so that's the vision. The mission for the Center of Excellence is really, again, collaboration, right? To solve these problems and advance the efforts, that we have to have cross-organizational, interdisciplinary working groups that have a platform to come together to identify topics or issues of importance and then work collaboratively together to develop truly viable solutions, right? So that's really what the ultimate goal is here, is getting everyone that needs to be around the table to be around the table, having the flexibility to say, here's an issue that I've got, and collectively, let's not talk about the 99 reasons that have prevented us from collaborating in the past. Let's talk about the one reason that we can start the collaboration, right? And one of the models that we talk about a lot is you can't eat the elephant in one bite, right? You got to eat it one step, bite by bite. So the goal that we're going to talk about is start very, very small. Okay, start somewhere, right? You're not going to solve everything at one time. Start with something that we can have quick wins on, and once we achieve that, then we're building a trust relationship, and we can expand that on. Okay, so a big thing that we're talking about is small. Start small, quick wins, and grow the trust and go from there. So this is the goal: identifying the opportunities, creating the cross-disciplinary working teams for collaboration, and then collectively working together to create some solutions, demonstrations, and best practices and recommendations. The goal is these best practices and recommendations then is anyone can leverage that, whether you're a payer, whether you're a constituent, whether you're an HIT vendor, it's common knowledge for everyone. So everything we're doing here is open. It's open standards. The goal is whoever, any organization can take the outcomes here and incorporate it within. So again, it isn't about competition, it's about openness and sharing of information. And again, so the key is around these working committees, and we're going to talk about what these working committees are. But the goal again, and the outline is, anyone can identify an issue that you have. And again, just within this room, we've got a lot of different stakeholders, a lot of different perspectives. Okay, one analogy I use a lot is, value-based care is like dropping a pebble in the pond. Right? It doesn't matter who drops the first pebble in the pond. that ripple effect has to take place until that ripple touches all boundaries of that pond, right? So it doesn't matter where we start. Again, one thing that we have in common is a patient that needs collaboration and coordination of care. So again, anyone can identify an issue that you individually have, and then what happens is at the center, we'll circulate those opportunities or issues with membership, with a group. And anyone can say, I've got an interest, I have an interest. Once we identify who's interested, then the formation will take place. And we can have multiple working teams, and we already do have multiple working teams, where each working team can have a chair or a co-chair. And again, they'll have a cross-functional interdisciplinary working group that works together, okay? And they work together to again, solve problems. Okay, so that, and we're going to step through a model of that, but again, at a high level, that's what we were doing. That's what we're all about. And since the last meeting in November 5th, we just had an incredible amount of very, very positive reactions and positive interest from a lot of different stakeholders and groups. So it's great to see. Okay, from an organizational perspective, this is still, again, this is the second meeting. So there's a lot here. Again, I'd like to thank Randy and everyone at OU for really being the anchor to help kind of bring this together and provide the facility and provide the opportunity for us to kind of meet and talk. But the structure we're going to continuously kind of work through. Okay, right now we've got an interim board. Ultimately, we're going to have an advisory board. And as I talk through the structure, I want everyone to kind of think about where do you think that you would like to play and where do you think you can add value? Okay, because again, this is open, and one of the goals we have is that as we talk through the structure, as we talk through the working group committees, then individuals are going to be stepping up saying, this is where I want to fit, this is where I can add value. Whether you're a chairperson, whether you're a committee member, whether you're on the advisory board, it doesn't really matter. We're looking for your input, your feedback, and your volunteering in many cases. So this is how it is. Again, it's an advisory board. We'll have an executive committee. We'll have a team. Membership and funding is a committee which is focused on the long-term viability of this. We're going to have some discussions about that. And again, the goal is around these work groups. And these work groups right now, we've already got 5 of these working groups that have been we're starting. Some of these, and we'll talk through the model, we're much further ahead. And in many cases, this isn't new, right? So in many cases, we've already been having discussion over the last several months, and we know what the topic is. And we know that some of the issues are the lack of collaboration. So in many cases, this is just advancing efforts we've been working on already, right? So that's from a structure side. One of the things we're doing is we've created these task groups. And in this case, we're working with the folks at ICE Miller. John Oberle and Marilee Spring are both partners at ICE Miller. One of the things we're looking at now is to basically stand this organization up and to provide the resources and provide the flexibility and to provide the ability to scale. There's a lot of different things that we're looking at how to structure. Okay, so one of the things that just as a point is that we have a task group right now that's coming up with what the different options are. And they're going to be recommending those options, and hopefully the next meeting we can talk about what we're doing on that side of it. And there's a lot of different options here. One thing for sure is that what we're doing here for Value-Based Care Center of Excellence is a common thread across the country. It's a common problem across the country. So being able to create a model here that's easily replicable across the country, so that again, there's power in my numbers at this point. That's the goal. So just so you know, we have a group that's kind of a task force that's working on this. They're going to provide the recommendations. Hopefully this next meeting we're weighing out what different options are, and we can talk about what we're doing from the structure side. Okay. The other thing, just as a touch point, is there is a Value-Based Care Center of Excellence site that now is in development, will be launched by the end of this month. Okay, so this is a website that everyone and anyone can go to and share, and it talks about our vision, talks about our mission. It'll talk about the working group committees. Okay, it'll allow any individual to basically put their ideas and their thoughts, or to basically volunteer for things. Okay, so this is going to be an open resource, again, to promote collaboration. So again, this is in development now. All of these meetings are being recorded. Okay, and all the presentations and all the comments are being recorded. All the working group meetings will be captured as well, and everything's shareable through the website. Okay, so this will be a great resource for everyone to basically go and learn and share. Okay, then just rapidly going through the agenda, membership and funding committee. Again, this committee is going to be designed again for long-term viability and funding and sustainability, etc. Okay, so there's multiple options that we're looking at. The first one is, again, is grants, endowments, donations. Okay, there's a lot of focus and there's a lot of grants that are available that as a group, as an organization, as collaborative, we can go after that. And the other part of this is around the membership dues. Okay, and from a membership perspective, again, right now, the proposed structures, there's going to be really 3 levels of membership. Okay, the first, the base level is an associate membership. And the goal here is not to exclude anybody, right? So at the associate member level, again, if you're a student, if you're in a government agency, whoever it might be, they can participate and learn through these discussions, and there's no cost for those associate members. Okay. The core membership dues will come from the members, and it doesn't matter if how large or how small or what the business is. Based on the overall revenues, there's very nominal member dues that would be available, that would be there. And then the third level is for the sustaining members. And the sustaining members are for those larger organizations that really want to tie their name to value-based care and help promote this on a sustaining membership level. And those are tailored much higher. And the exciting thing is we've already have several folks that have stood up and said, we want to promote this in the sustaining membership level. And again, this is a model that we're replicating from what we've done in the national security space. And these are relatively small amounts, but they go a long way to help support the things that we want to do. Okay. So that's where we are from a membership structure. Similar, the other task group that we've created is the funding task group. And again, as we mentioned, there's a lot of different options for how we can kind of collectively work together to get the funds so that we can build these working teams, do the pilots, do the demonstrations, and move collaboratively going. So at this point, I'm not sure if Christine's able to.
Well, I can say whatever I want about her, and she can scream at the top of her lungs we might hear. So,
okay, you want to do this?
Yep.
So I'm going to introduce, this is Chris McGill. Chris is with ICE Miller. He's the Economic Development Director. On the line, but we're not going to be able to hear, I don't think, is Christine Dodd. She's the Director of Public Affairs for ICE Miller. And they've been spending some time looking at different opportunities from a funding perspective. So, Chris, I'll let you.
Sure. Can everybody hear me?
Yes.
Yeah, I won't go over the microphone. One of the things that, as far as, first off, Christine has a lot of experience with technical grant writing. So if you have very technical questions, I'm going to try to keep this high level and general and to speak in considerations we might want to make when looking at funding different elements of the center. So, she could probably handle some of those questions. No, she's not going to be able to respond to those. So you can put them in the parking lot and email me afterward or email Christine and we can answer those if you have some. One of the things I'll also mention is a table setting item. I'm going to speak in generalities, as I just mentioned. So I'm going to go over when to consider grant funding and categories of operations, what you should think about when establishing one of these centers. I'm not going to get into technical details about medical technology. My dad is an optometrist, but if he knew I was up here talking about medical technology in front of the Optometric Association, he'd probably kill me. So I'm not going to get into that. So going into slide. So here are some typical sources, and I'm going to try to keep this simple and then get into some specific programs. I break really the funding of the center down into 5 categories. infrastructure, facilities, and equipment. You're not really going to see a lot of that here. I don't think there's anything in immediate plans to build a building, but there are options to do that and be sent and buy long-term equipment. Catalysts, this is really what we are probably going to focus on first. Startup funds, what can be awarded through grants, foundation dollars to start your center. Project specific, this is probably the stuff that most of you have heard of if you're involved in the grant writing world or understand that grants. And that's basically a research project. Whatever those working committees are doing, that's what that's here to fund. Outcome specific. This is really a shift in what state government's looking at now. So the Kasich administration is getting away from funding facilitation of universities and private industry and more funding the outcomes and the direct job creation or the licensed technologies, so on and so forth. Ongoing operations, that's just how we sustain the operation of the center. Sources, so as I just mentioned, foundations at the state, regional, and federal level. I think a state regional about caring about the impact on the community with the deviation of goals. And I think of federal as far as big, bulky federal organizations, you split into two ways. Some of them kind of mimic what the local organizations have, community goals, and the other ones have, like the National Science Foundation, have numerous grant opportunities, depending on what your working committees are working on. That state and local governments and quasi-governments have funds, have grants that they award these types of collaborations. One of the things you rarely will see is on the local level. So the city of Dublin may not have something in their toolbox. They may need more of a support system to help facilitate other types of funds. And then membership. Federal. There are some programs with federal through a combination of foundations, federal government, the Economic Development Administration fund these types of ventures, and then membership, which James just discussed. This is kind of taking the two categories and matching them up. I set a laser pointer. Or am I going to hit the alt button here? All right, there we go. So this is really the categories I just mentioned. I like to break project and outcome into two subcategories. Now under outcome, I just picked two, but these are the primary two you typically see. Project, we've got industry issues, and then if the working committee wants to undertake a project that has to do with student job placement, workforce training, whatever that might be as it pertains to this initiative, that could be an example of a project that could unlock a different box of funding. Outcome specific, think about technology transfer, the commercialization of a product or an idea that comes out of one of the working committee initiatives. There are funds to assist with that transition and that commercialization effort, whether it goes to a startup company or whatnot. And then ongoing, as I mentioned, as you can see, this is kind of, you can see how this deviates a little bit by type. You see where foundations in the federal government typically like to contribute their funds. The next slide, this is kind of, and this is really what I think you want to spend the most time on. Now, I can't say enough that it's important to understand that as initiatives change and evolve, and working group or working committee projects start to crystallize a little bit, you'll have a better idea with what these are. And essentially, I have the categories we've mentioned with specific funding opportunities. So on the infrastructure side, there's a group called the Finance Fund. They typically get into these public-private projects. I would classify them as a nonprofit, non-traditional financing mechanism for certain initiatives. Again, this is on the infrastructure side, so I won't spend much time on that because we're not talking about building a new building for this. The catalyst. So there are a couple, and I'll get into some of these individual programs, but this is where we're looking at foundations, we're looking at National Science and National Institute of Health sources, and then our founding member grants. So when you think about sustaining members, or if any members of the organization want to put together some grant programs, you probably noticed this. Akron had a similar center of excellence that has been underperforming that we really looked at. we looked at long and hard because we want to see best case scenarios. But we also want to see worst case scenarios when we're looking at these things. But point is, Akron had a series of founding members that were contributing grants up front. Now also they had a large foundation known as the Knight Foundation that put together about $20 million into that venture. However, the founding member grants are what really you want to look at in the catalyst stage and then in the ongoing stage. And this program here, I'm going to get into some examples of this. So if you have questions on that, you can hold those and see if they're addressed in the next slide. On the project side, and this is really, again, where you've probably noticed the bulk of some of these grants coming in from your experience as practitioners or facilitators. And, I think this R01 grant is a research grant given by the National Institute of Health. There is a center at Case Western Reserve that has acquired 300 of these already. I mean, this is really what you want to look at when your working groups are undertaking a research project. Again, without getting into specifics, and I'll mention this later, there are varying compliance requirements and rules and initiatives with each grant program, but it's good to understand where some of these come in at each stage. I've got activity-specific National Science Foundation. There's a bit of a dichotomy between the National Science Foundation and the Institutes of Health in what category this initiative would fall under. For the most part, you'll see National Institutes of Health Foundation funding. However, the Science Foundation has a series of programs that delve into this category. So when we were looking at grantors, one of the things we made sure we looked at was how many of these other foundations actually delve into healthcare and value-based care. On the outcome side, I think this is interesting to mention. This is really where you'll start to see the state of Ohio and some of the governor's initiatives and maybe the Small Business Administration get involved. Because this is typically, oftentimes this leads to direct job creation of some sort. So you're actually looking at an initiative, an idea, a concept that moves from the idea stage to the commercialization stage, where you'll have some technology that needs licensing. That's where you'll start to get funding to help facilitate that process from the state. And I'll mention kind of some of these programs again on a future slide. And then ongoing, as we mentioned, this program here is awarded in multiple phases. So you'll see a couple examples of where a university has secured this award to help catalyze their center, and then kind of went back to the well to get more grant funding for ongoing operations. And then, as you can see, I mentioned foundation and founding member grants. It's important to make sure you're continually tapping into those sources to sustain the center. One of the themes, another theme I'm adding to this now, is just make sure that in the Akron example I gave, part of the reason it was underperforming is it was very few large sources. The center was dependent on a small number of very large sources. So when one of those would dry up and they're spending a lot of money, there's a high risk involved with that. So that's something that I think we looked at specifically. We want to be able to spread the sources so they are able to satisfy each use of the center. So, when we look at foundations, one of the things we started to do is we just kind of cataloged some of the foundations in Ohio. Now, Ohio, I'm saying roughly 40 area foundations. I know there are a handful more, but as we looked at this, we looked at foundations that cover, of the foundations listed in the state of Ohio, there were 19 that were healthcare related, and these are the two boxes we have to check with foundations. They've got to cover this area, so they've got to cover the Columbus area or the city of Dublin / Union County. They need to make sure they cover that jurisdiction. If you look at the list of all the foundations in Ohio, they have varying jurisdictions. And most of you probably know that. Related missions and grant criteria. So then we took that list of 40, so the 19 includes area jurisdiction, and then it also includes the key criteria that would somewhat align with the goals of this specific center, which is important because you're not going to get foundation funding if your goals don't align with foundation. So we had a couple examples, and we have lists of all these and some of the annual giving that you typically see come out of these foundations. Cardinal Health has a foundation, CareSource, Patel, some of the larger companies that have foundations. And then you've got a few smaller foundations that are, well, I don't want to say smaller, probably lesser known foundations that typically fund these types of interests as well. Lastly, you've got some national / out-of-state foundations that have a history, and really searching for this was just looking at kind of activity and appetite to fund a center of excellence, not necessarily just foundations that look at healthcare, but those that could tap into this type of operation. There's a, oftentimes when you look at certain foundations, you see that some will fund healthcare initiatives, some will fund healthcare research, some will fund healthcare's impact on the community, and then some will fund university collaboration. We really looked at the latter. So, here's an example of some of the grant activity you've seen from federal foundations and programs. The first, so when we look back to that continuum, we have the catalyst and the ongoing stage, where we have this industry university cooperative research center program. That comes out of the National Science Foundation. However, they fund areas that extend to healthcare and IT. And when you look at this, here are a couple of awards that have been given. Now, granted, these range. I think the expectation is to think small in some of these grants, because if you look at the grant activity, it's rarely do you see them go up to 1.5 and 2 million. They do if the project merits such, but you really have to understand your cost before you apply for these, as everybody knows. So you've got a couple examples of when this was done. You've got one specific. So the IUCRC has been awarded in Ohio 18 times. You can see a couple of examples there on when it's been awarded. Can everybody read that? Or is that too? And then the second, and so this also kind of gives you an idea of how specific these grants come. And here you've got grant opportunities for academic liaison with industry. This is another program that funds this type of operation, and it's something to think about when you're evaluating opportunities. This is awarded 21 times in Ohio to 6 different universities. One thing I've noticed is there's not a large quantity of universities. It's really a small number of awards to a specific set, small number of universities, and that's worth noting when you think about the frequency of when these are awarded. National Institutes of Health, they have the RO1 grant that maybe you're familiar with, maybe not. Case Western has used it numerous times, and their Center of Excellence is translating technology and research into better health. But they've been to the well numerous times in this program. And then the U.S. Department of Health and Human Services has a Center of Excellence grant program. However, there's a minority element. It has to make sure it lends itself to minority students and creates opportunities for minority students in what a liberal definition of an underserved area is. So this, and I wouldn't spend too much time on these specific programs themselves. While we think these would satisfy what we're trying to do, there are numerous programs for those working committees to consider. So as that working committee is starting to be formulated, it's important to understand what that budget would be, and if that initiative that's brought forward would satisfy one of the many grant programs that are out there. State and local considerations. This is very important. Over the last 5 years, state funding for university collaboration with private industry has changed dramatically. I'll give you a specific example. The Akron Center of Excellence that I brought up a couple times was awarded a $7 million Ohio Third Frontier grant. Just 2 years ago, the administration made a decision that they didn't want to continue with that program. That program was a lion of a program for a research and development center of excellence. Really what we're doing here. It was a 50% cost share, public-private sector, so university and private sector collaboration. Because that is gone, the governor's office shifted their viewpoints or their initiatives to what comes out of these centers. So Ohio Third Frontier now funds outcomes more than they fund concepts and ideas. So that's important to know. So when we think about what the state would be willing to do, it's really in 2 areas. It's in commercialization. it's in technology transfer, and it's in workforce development. So if you talk to the Ohio Board of Regents or the Ohio Department of Higher Education, their values and their interests would be in those three areas. And it's important to understand, as you're looking at what these working committees are able to do, it's worth looking at what's the impact on being able to place potential students into jobs and getting them involved in some of these research activities. So here are a few other programs to consider. You have university research grants, and I listed a couple examples that you can see at OU that I'm sure a few of you are familiar with them on the smaller end. Advancing health services through system modeling research grants. And this is what I'm talking about. If you look at some of these grants, these are just a handful of a large laundry list of grants that you'll see, whether it's through NIH or it's or the Science Foundation. And it's important to understand, really, these help drive down that programmatic cost of some of your research projects the working committees will undertake. Last, you've got and I'm roping the Smart Connected Health grant with this grant here above. And then the bottom two, federal EDA grants, the Economic Development Administration at the federal level will award certain initiatives that they think promote economic development in the community. This would be an example of one of those initiatives. Because Central Ohio is eligible for these grants, typically you have to get your project listed and you have to get your project listed in advance, which would be this Center of Excellence, and you need to articulate to the federal government what the impact will be economically to the area, and I think you can do that with this initiative. And then last, Small Business and Technology Transfer Fund. You see this come out of the Small Business Administration quite often. And this is one, again, an outcome-specific funding box check. So that said, I went over this rather quickly. I try to keep it high level. I think if you take anything away, I would take this away. Opportunities exist in all areas of the life cycle. So think about that life cycle that I just laid out. While foundations and founding members should primarily serve as catalysts, startup grants do exist. So understand that there are grants to help start these centers. Even though typically it's a foundation or founding member grants, there are catalyst grants at the federal level that can help start, that I detailed in a few slides before. Grant opportunities should be factored into working group topic selection. I think I mentioned that as your committees are getting together. You may want to think about, okay, if I'm evaluating this topic versus this topic and what our committee wants to evaluate, I might look at the cost associated with, or the cost reduction associated with being awarded one of these grants. And then grant opportunities could influence a larger variety of your service offerings for the center. So you may decide to get more into workforce development and training students and placing them into jobs with some of the members if there's enough funding there. And each grant requires a separate set of compliance requirements and grantor involvement. This is often the takeaway that no one really cares about, but it's the most important. Writing some of these is very time consuming, and the compliance requirements vary grant to grant. The goals vary grant to grant. The initiatives vary grant to grant. It's important to understand exactly what the risk is of applying for that grant, the probability of getting it, and what you have to do to comply. And I think that's something to always consider when starting to undertake one of these projects. And that is it.
Chris, thank you so much.
No problem.
So again, there's a lot of thought and energy going around this. Again, obviously, when we talk about the gaps to really promote value-based care, we talk about known technology gap, right? We know we've talked about the collaboration, which is required here, and the funding is obviously another one, right? Everyone here has things that you want to do that can be more effectively managed as a group, as a team. Okay, so and the goal is that these key topics will find the funding to do these projects because they have to get done, right? And it's a lot. There's strength in numbers here. It's a lot easier for us to identify working groups, bring groups together to get funding to kind of advance these very, very important causes versus trying to do these one-off. Okay, so I think it's an incredible opportunity. And again, I know we started late, we're going to quickly jump through these working group committees. I know that Chrisanne is going to have to leave. One of the, just for background again, since the last meeting, we've kind of floated out there for the participants to say, tell us areas that either you're working on now or areas that you think are of high interest. Okay, and there was probably about 50, close to 50 respondents. Respondents, and this is kind of the ones that have come up where there's been some critical mass around them. CCM, chronic care management, I'm going to talk through. That's a big opportunity that is out there that very few individuals and groups are going after right now because of the complexity of that. Okay, but it's a major opportunity that is value-based care. So we're going to talk, I'm going to spend a lot of time on that. Before Chrisanne has to leave, one of them is around traumatic brain injury and post-traumatic stress. And I'm just, if you can just maybe spend 2 minutes.
First of all, I really apologize, everybody. I actually have to go across town, and by 4 o'clock, I'll be speaking to a group of West Point psychiatrists as to why our young heroes are out of their brains, not out of their minds. So that's what, and that couldn't be rearranged. So just briefly, first of all, I want to thank you very much for the opportunity to be here. Dean Lang, I really appreciate. You don't know how much I appreciate Ohio University. Dr. Fredericks, Todd Fredericks, you're a Iraq veteran from down in Athens, was the only medical school to listen to us. When we said we've got 15,000 young men and women with traumatic brain injury and post-traumatic stress disorder, probably another 12,000 in the state of Ohio, what can we do? And you were the only responder. So I really, really appreciate that. The most interesting thing about this, and Dr. Debbie Misek here is the Chief of Staff at Chillicothe VA. She is my mentor into the government system. We have a young, healthy group of individuals with a chronic illness, and that is very bodily healthy 20-somethings with traumatic brain injury, which is considered a chronic illness now, because of the effects of ongoing brain injury. So I have to say that James was just like so wonderful. I'm so non-techie to be doing all this techie stuff. And when I looked at his model for following diabetics and hypertension, I go, that doesn't help any of my guys. My guys don't have that. What they have is memory issues, sleep disturbance, difficulties with social interactions, you know. And right away he said, he goes, well, we'll just change that model. And I said, I really like this guy. You know, so I'm very sorry that I have to leave, but I'm very, very interested. The brain is the new frontier. You know, we can now look into it where we couldn't before. We're beginning to understand that post-traumatic stress disorder is a chemical form of brain injury. And I just think that for your medical students, for the future, it's a very important place to start. So I would look forward to being with you. And I'm lucky, I'm in the nonprofit group there. The member's not charged. So, because this nonprofit is killing my retirement fund. But I really appreciate it, and I hope to be more available next time, and I'm really very sorry about this. However, anybody who wants to know anything about TBI, my mentor here, Dr. Misek, is going to be available for that. So, and again, Dee, thank you so much for this wonderful facility.
Great, thanks. I know you have to.
I'm so sorry.
No.
You know, here's my problem is how many people are going to diagnose me while you're talking. You know, you've got nothing but, I tend to be hypomanic, and you got 70 psychiatrists looking at you thinking, lithium?
Don't worry, Chrisanne, they're all more crazy.
Thank you all so very much, and I look forward to the future here.
So again, this is one of the working committees where there's been a lot of interest because there's a lot of cost associated with dealing properly with a patient that's been diagnosed with either TBI or PTSD, right? And you know, Chrisanne has had to leave, but there's been a lot of, you know, once we floated this, there's been a lot of individuals that said, hey, yes, this is something that we want to be part of as well. The other feedback we had was around social services. Social services is around, again, to identify the true risk of these patients. You have to look beyond the clinical aspect of this, right? And we hear that 15–20% of the clinical of the health determinants are clinical. The rest of them are social, behavioral, environmental, right? So this is a big, big, big area that needs to be focused, right? Because again, 15% of the patients make up 85% of the cost. The goal here is identify where those highest risk patients are, and you're not going to do that unless you look beyond just the clinical aspects of this. So this is a very, very important area of social, it's called social services. The input and the feedback was around being able to have a needs assessment so that, again, we can do a comprehensive whole person perspective to understand, okay, if this is a patient that hasn't worked for 12 and a half months, okay, what are the issues? What are the risk issues? Well, if you've been prescribed medication, you're probably not going to be able to take it because you can't afford it, right? If you have to follow up with a doctor visit, you're probably going to miss that because you don't have transportation, right? You probably have bigger issues like I need to put food on my table and I need to find a job, right? So all being able, if you're the inability to link that is a major, major hole and has to be addressed. And there's been a lot of responders around saying, yes, this is very, very, very important. I know there's a lot of efforts out there where there's groups and organizations saying, we're going to put together energy around, this population, or there's a lot of these. What's nice is there's a lot of social service organizations out there, large and small. The goal is how can we create a registry, a holistic registry that allows, once we do the needs assessment for a patient, for a system to be smart enough to say, here's potential areas that we can refer them to, right? And then facilitate that process. So that's one of the working committees that again, there's been a lot of energy around. Mental illness, behavioral health, diabetic. Again, when you look at the chronically ill patients, those are the big, big cost areas, right? Diabetic patients, asthmatic patients, COPD, mental illness, behavioral health. When you go back to chronic care management, and I'll spend a lot of time on this, it isn't a one-size-fits-all like Chrisanne mentioned, right? The risk for a diabetic patient and the protocol and how to reduce that risk, and again, improve the quality, improve the cost, improve the satisfaction. What you do with that patient is very different, right? So part of this is, okay, if a provider does the needs assessment and one of the needs is this patient has TBI, there should be a separate protocol on what we need to do to reduce that risk for the TBI patient. If the patient has mental illness or behavioral health, what do we need to do to reduce the risk there? Diabetes and so on, right? So a lot of these are similar where it's a very patient-specific, because again, when you talk about the tailored care plan, care coordination, it's got to be tailored to the patient, high-risk patient. So mental illness and diabetic care are two areas. Reporting and analytics received a lot, and that's kind of a general area that everyone said, listen, we know that with value-based care, it's all about quality metrics, right? It's all about being able to understand what quality metrics we need to assess, figure out how we're going to individually go back and put the infrastructure in place so we can capture that, can report to that. And there's a lot of issues right now with the inability to do that, right? The fact that a lot of these quality metrics are relied on, the value-based care systems basically, determine, reimbursement levels based on these quality metrics. But the fact that there isn't any near real-time way that a provider can get that feedback, right? So the reporting and analytics is one where I imagine that this is going to probably turn into 3 or 4 very focused opportunities. With FQHCs, the UDS measurements have been a big one. So there's a lot of them. They're talking with the payers. There's 6 pay for performance quality metrics that it's important for them. Okay, so there's a lot. I think that this is going to fall into probably about 3 or 4 more specific working groups, and then medication management. Medication management is a big thing because as we start bringing information together across providers, okay, for the first time you're going to be able to see that this provider diagnosed a patient with this, and this was their care plan. Here's medications. This provider, for the same patient, this was his diagnosis, here's the medications. Being able to have a group, an organization, or a person have a holistic view of that and saying, okay, now that we're bringing this stuff together, I can identify where there's issues, where there's potential conflicts, and help resolve those conflicts. So this medication management is a big area. So each of those groups then we've kind of looked at it, we've gotten some good input and feedback, and we said, okay, let's start structuring these working committees. Again, Chrisanne had already, Dr. Gardner already talked about the TBI piece of it, and she's going to be the chair or co-chair for that TBI working committee. Medication management, Ernie is here right now. Ernie's the executive director again at Ohio Pharmacists Association. And Ernie, I don't know if you want to introduce yourself and talk a little bit about the significance and the importance of this approach.
A couple minutes. I am a pharmacist. My wife's a pharmacist. My son's a pharmacist. I'm engaged in it far too much. But I was so pleased to be a part of this because when you talk about chronic care management, the way we treat chronic care, whether it's chronic disease, diabetes, heart disease, whatever, is usually medication. The thing that people don't realize is that we've measured, did the physician write a prescription? Did they write the right prescription? Yes. But 30% of the prescriptions are never filled, okay? 30%. So that leaves this huge gap. But then you look at the rest of the scripts. Of the 2/3 that are filled, 50% are taken wrong, resulting in 10% of all hospital admissions. And I can back that up through all kinds of figures for the last 25 years. Nursing home admissions, 20% of nursing home admissions are tied to medication misuse. Now, what this has resulted in the past 10 years, and I've copied a number of articles on the table over there next to the cookies. If you're interested in more information, it's over there. But my snapshot is this. When the pharmacists get involved, it changes the picture. When Anthem did a study down in Cincinnati, I believe it was 4 years ago, with pharmacists at Kroger's, by the pharmacist going face-to-face with the patient and slowing down and talking to them about their diabetes medications, they changed the number of patients hitting the A1C to just 50% of the employees of the city of Cincinnati to 75% in 1 year. The impact on blindness and on all the other sequelae from diabetes is tremendous. And the other thing that we're seeing out there, and I've given you just one piece of paper in front of you, this medication therapy management, and don't be offended by model of pharmacists as the medical home. This was written by pharmacists, so sometimes it's not, a little different. But if you look at highlights of MTM, identifying drug-drug interactions, prevent the unwanted side effects, therapy individualized and optimized, the new therapies that are coming out are usually $100,000 per year. So if they're misusing those, we not only have hit a hole with the disease itself, but the product is worthless. There was just Wall Street Journal article 2 days ago about a group of patients that were given an HIV, I believe, a vaccine type product. And the only problem they ran into was with one specific group where they did not adhere to the medication regimen. So high-cost drugs, transitions of care. Here in Ohio, we've got down in Circleville, the hospital there has a relationship with community pharmacies. There's an article over there, a national article about that, where the hospital says, here's what we're releasing the patient on. If they don't fill them, we get back to the doc. So at the end of the day, this whole medication therapy management is a team approach. It's not just the pharmacist. You have the nurse going in the home, finding out that literally, I heard this the other day, a patient puts their meds in one fishbowl and takes what they remembered the last, which was 1-3 times a day, out of the fishbowl of the mixture. Between us, we can make things happen, the physician, pharmacist, and social worker, but for years we've operated in a vacuum, or at least in silos, and I think that this effort is really going to solve a lot of issues.
Great, Ernie. Thank you. Okay, so we're very excited to have Ernie be the chair for this effort. Again, one of the discussions that Ernie and I had individually was that there's all these models of care right now. There's a patient-centered medical home model, there's these accountable care, there's these episode of care models. And one thing that seemed to be lacking was the pharmacist's role in these care models, right? And the reality that a patient probably visits their pharmacist more times than they visit their primary care physician or their specialist, and it's probably personally knows a person more. It doesn't make sense to have those pharmacists as a critical member for the care team, right? Not as an optional member of the care team, but a critical member of the care team. And I think that's the thing. So when we talk about our chronic care management overview and solution, when one of the big risk areas driving the cost is the mismanagement of the medication or the reconciliation or lack of that. I think this is going to be a really critical part of that. So we're excited to have you as part of that. So these are the current working groups. Again, chronic care management. I'll help drive. Again, we've been working with Laurel Lights and Ann Shealy here, but we're going to try to. There's been a lot of focus and energy and discussion around this already. And one thing I wanted to do is to take these working group committees and show you again what the starting point is. And each of these committees, again, are going to take a life of its own on, right? There isn't a one size fits all, one model fits all with these working group committees. So some of these committees can define issues where the working committee, the members that need to come around the table, it might be 3 or 4 people, and they can have, a project that can last a week or 2 weeks. And you could have some of these working group committees where it might be 30 members and it spans years, right? So and what will happen again is there's this iterative design that basically says once we peel back the onion, we're going to find other issues that we need to address, right? So again, these working group committees are ideal. Again, call to action is if any of these areas strike a chord with you, then let us know, and we'll make sure that we put you in the appropriate team. If there's other opportunities that aren't up here, let us know, and we'll make sure we kind of put this around as well. And again, the goal with the center is identify where the biggest issues are, put together the right energy and right focus to solve those things. Okay, so in the last few minutes, what I want to do is just talk about the chronic care management group, because again, this is kind of like the glue I see, right? So chronic care management it's a value-based care with a nice fence around it, right? So what's nice about it, again, it's all about promoting really the tenets of value-based care, which is identify where these high-risk, high-cost patients are, coordinate information, coordinate care to better improve and reduce the risk and reduce the cost, right? And the nice thing with the chronic care management is it's a nice fence and a really healthy incentive that's available to providers if they meet the requirements. Okay, now chronic care management started in, the CMS basically started this in January of 2015. And they've provided some, again, really attractive incentives to providers, which is a per patient per month fee that's available to them if they meet the requirements of chronic care management. CMS reports that roughly 35 million Medicare beneficiaries and about 50 million Medicaid beneficiaries are eligible to receive this incentive payment. But as of today, less than 100,000 of them are actually doing it. Okay, so it's pretty incredible, right? And this is value-based care. The whole purpose for chronic care management is let's put incentives so that providers are managing patients with 2 or more chronic illnesses. Again, the 15% that make up the 85% of the cost, let's give them the resources so they can better manage that. Yet less than 100,000 have been collecting on that right now, right? So that's a major problem. Some of the chief complaints for this is vary quite a bit. One is from a individual provider perspective, it's too much for one provider to handle, right? They've got to understand what the requirements are. They've got to figure out how they individually, as a single provider, is going to meet all these requirements. Okay, and a lot of them are saying, it's the documentation's too lengthy. The investments I've got to make are too great. I just can't do it as an individual provider. Okay, the ability for the Center of Excellence to create a model so that there's strength and opportunities in numbers where now we can address this across multiple providers is a huge opportunity here. Okay, co-payment. There's a lot of these issues that we'll talk about. So from a working group, the goal here is let's identify what these key barriers are for advancing CCM. Okay, let's develop and test viable solutions by, again, building a collaboration around the table. Let's work with multiple pilot groups to make sure that there's applicability across it. So whether it's an FQHC or whether it's a private practice or whether it's a larger doctors group. Again, making sure that the model and what we're addressing is universal enough to be addressed. Okay, so, and again, it's a guys iterative design where we're all kind of figuring this out together, right? And again, things are going to change. Today we're going to make the best decisions we can make based on what we know today, but guess what? After tomorrow, we're going to know something else. So the goal is kind of to iterate through the design process. And then the ultimate goal is in working with collaboratively with the teams, working with the pilot groups to document our findings and recommendations, and then actually have a working demonstration center that allows other people to learn from this effort. Okay, one of the issues right now is that everyone has the same problem, and we don't want them to have to try to recreate the wheel each and every time, right? If there's an effort that says, here's a best practice, spend your time, use the money and your time in implementation versus in design, that's big opportunity for all of us. So from a goals perspective, that's what we're doing. Again, looking at what these key issues and barriers initially that this working group wants to address. We put them in a few categories. First one is around documentation. So the burden of documenting chronic care management, one of the requirements is not only do you need to identify patients with 2 or more illnesses, again, the goal is at least 20 minutes of time need to be tracked. Okay, so documenting that is a big issue right now. So how can we better manage that for the providers? The fear of penalties for not having that documentation has been one of the stated reasons why a lot of these providers aren't going after that. They're thinking from an individual practice, I can't do it on my own. We're allowing the opportunity not to do it on our own. Okay, copay is another major barrier, right? So for Medicare patients, chronic care management, one of the challenges is that the patient is subject to their monthly deductible. Okay, which is going to be detrimental to this high-risk, high-cost patient from participating in this effort, right? So it's a major issue that has to be solved, right? And again, these are discussions that you need to have collaboration with everyone and say, listen, here's a patient that needs to have this coordination of care, and if they're not, because this high-risk patient can't afford the medication, they're not going to afford their copay. Right, so this is something that has to be worked through. The lack of clear ROI, again, from an individual practice perspective, for them to say, okay, to do this, I need to make investments in technology. I need to hire care coordinators. I've got to train them. I've got to track how we're going to manage the documentation of all this stuff. What a lot of these providers are saying is, I can't do this. The incentive money that I'm going to get as part of this, I'm lucky to break even based on what I have to outline, right? So how do you make this more compelling of an ROI so that each practice isn't having to try to figure this out themselves and there's economies of scale, right? That's one of the key goals for this working group. Another issue is questions on the ability to actually improve patient outcomes. That's what this is all about, right? So chronic care management isn't about spending 20 minutes to do whatever, okay, to collect payment. It's about spending 20 minutes to basically identify what the real needs of that patient are and what we can do to reduce the risks and improve the patient outcomes. So again, that's a big area for this working group is everything. It's not about meeting the minimum requirement to collect payment, right? It's about advancing and improving patient outcomes. And we've seen that as a problem all along, right? Where meaningful use. What's a minimum? What do I need to do? What's minimum I have to do to collect minimum, meaningful use dollars, right? Having one of my patients go onto a patient portal, is that really improving patient outcomes? No, right? So again, the goal of this whole thing is to improve patient outcomes, and everything will tailor back to that. The other major issues is there's technology gaps we talked about. Right, so the EMR technologies weren't designed to support these new requirements. So tracking the time, reporting the time, being able to have a care plan that's a whole person care plan that's shareable across providers. Okay, that's not what these EMR systems were designed to do. And that's a big challenge. So that, from a technology perspective, that has to be done. From a billing perspective, again, there's less than 100,000 of the millions of patients are doing this right now. Okay, so there's a process, and there's a lot of uncertainty as to how am I going to bill the Medicaid? How am I going to bill the commercial payers? How am I going to bill this so that it doesn't come back? What documentation is required to do this? What is the payment? One of the stories I'll tell briefly is for the federally qualified health centers, right? Medicare originally said FQHCs aren't eligible for this chronic care management fee. Since then, they basically said, well, no, we take that back. They should be eligible. And again, that's where the high risk, a lot of the high risk, high cost patients are. So Medicare changed there too, and Medicaid basically said, well, if Medicare is going to reimburse them, we certainly are going to reimburse them. And in fact, we're going to reimburse them at their existing prospective payment rate, which is much higher than some of these payments. So we thought it was phenomenal news when we were talking with Ohio Medicaid to say, yes, they're eligible and they get their prospective payment rate. When we brought that back to Ohio Association of Community Health Centers, and when we brought that back to the FQHCs, and they're saying that's a disaster waiting to happen if that's the case, because that is not a sustainable model. And if the FQHCs rely on this reimbursement level and all sorts to take it away, what does that do to the program? So that's just one example of needed collaboration where we can get the folks around the table to really think through some of these issues, right? And then the uncertainty again, from the physician side, are we doing this or what not? So again, from a working group, we said, listen, we know that there's probably a lot more of them, but these are key barriers as teams we want to address. Okay, and if you look at that, again, we know what the process has been defined, what chronic care management is, right? We've got to identify the eligible patients. We've got to get the consent from them. Once we have the eligible patient with the consent, we need to get their information together. We have to document a care plan. Then we've got to spend 20 minutes of care services and bill, right? So to really manage that, there's obviously technical considerations, there's service considerations, there's process considerations, and then there's measurements and reporting. Okay, this has to get done. And again, this is where there's a black hole. How do we get this stuff done? So again, looking across this, again, from a technical side, what are some of the challenges? And we've identified some of these challenges, right? How are we going to capture and store this patient consent agreement? Okay, one of the requirements has got to be stored in a certified EMR, right? Obviously, the underlying theme is how do we integrate information on this patient across, again, all these different providers. Some of them have different EMR systems, some of them have no EMR system. How do we integrate the information? How do we capture that care plan that's a holistic care plan, right? Clinical, behavioral, social, environmental. And then how do we share that across all of the providers that's part of that patient's care team? Okay, technical consideration has to get done. Care services, how are we going to track and record the 20 minutes, right? How are we going to do the needs assessment? What are the questions to ask? How are we going to refer, once we determine what the needs are, how are we going to manage the referral to the other providers? You know, how do we engage the patient? How do we coordinate care? Underlying themes that have to be solved, right? Billing and payment, the documentation required to do that. These are all technical considerations that have to be addressed. We're going to address as a committee. From a services side, again, care coordinator requirements, that's a big question. What's minimal requirements for this care coordinator? We've heard a lot of different things. You know, there's some folks that want to use community health workers. There's some folks saying that this person has to be an LPN or an RN. You know, so being able to sit down and say, what are the real minimal requirements for this care coordinator to be eligible for this payment? Okay, there's a lot of questions and uncertainty around that we're going to clarify. What is the proper team makeup for this? Is it a care coordinator, or is it a care coordinator team with a pharmacist to do the medication reconciliation? Those are things that we want to kind of address as part of this. And then this personalized patient protocol. And again, when you look at these other working committees, it's not a one size fits all. And it's not about spending 20 minutes to spend 20 minutes to collect payment. So if the chronic illness is mental illness, what should that care coordinator or care team be doing to reduce that? If the chronic illness is TBI, what's the proper protocol for the care team to do? So now there's a plan of action. It isn't about spending 20 minutes. It's these are the things that need to get done during those 20 minutes. Okay, 20 plus minutes. And so that's a big area that we're focused on. From a process perspective, again, addressing the copay. That's a detriment. How are we going to deal with that? Okay, we've already had some real exciting discussions with the payers addressing that, and I think we have some good ideas here. The compliance, the HIPAA compliance, obviously we're sharing information. It's got to be managed. Again, the billing process, and then from a measurement side, again, it's all about measurements, patient outcomes, ROI. So from this working group, this is just, again, a model, just to use as an example. All these other subcommittees, we're going to be doing the same type of thing, and this is kind of the starting point. So at this point, once we've identified these issues, the next thing we did was we said, okay, these are very different problems, takes a very different team makeup to solve these problems. Right, so what we've then done is we said, okay, we kind of separated all of these into really 5 teams. So from the chronic care management working group, we're going to have 5 task teams. And one will be focused on, again, what's in red. One will be focused on what's green. There's synergies there. Okay, so again, for anyone here or anyone that you're talking to, you know, if they're technical, they can provide value at one of these technical tracks. If they're service-oriented, they can provide value in these services tracks. If they're process or quality measurement, they can provide value here. Okay, so the goal is let's put together the right team. Let's get the right stakeholders around the table to solve these issues and these problems. That's kind of how we're dissecting it. Okay, so again, call to action is if you're from a process perspective, a technical perspective, a resource perspective, whatever it might be, let us know where you can add value. Okay, so again, I know we're going a little bit over, and I appreciate everyone staying. Next steps is this. Again, submit interest or desired working groups, what level of involvement you'd like to have, whether it's on a committee, whether it's on an advisory board. You know, talk amongst the individuals, talk amongst yourself, talk amongst your partners, talk amongst the community to say, listen, this is something that's very, very exciting to get involved with. Okay, and there is no competition here whatsoever. It's all about connecting dots. Okay, so you know, submit your interest. You know, one of the things we're doing is, again, we're completing the corporate formation structuring discussions. We're looking at the funding opportunities so that now these working groups can properly be funded. And again, commencing the working group strategy and planning and execution of those things. So a lot of this now is we know the 5 or 6 starting committees. Okay, that's probably going to grow, but we know where we're starting. Now, the goal here is about action. It's about deliverables. It's about getting things done, right? So to do that, again, the working groups now, we're going to start meeting individually. And again, each chair or co-chair of that, they're going to be basically creating their schedules. And they're going to say, okay, here's the team. Let's get together to solve these issues. And again, each of them can be a little bit different, but the goal is at least once a month, these working group committees are going to be talking to advance the cause. Okay? And again, some of these have been efforts that we've been working on for a while now, and this is just, again, a platform to get things done a little more effectively. So the goal is the working group committees, based on the chair and the team, they'll determine their meeting schedules. A lot of work will get done here at the working group committees. The board, the advisory board, the committee work groups, we're going to try to get together at least once a quarter. Okay, so we've kind of put up there the second Thursday for every month, where that group can be. This is going to get big very fast. It's impractical to get everyone together for every meeting. right? But what we do want to have is we do want to have twice a year, all committee, all member showcases and meetings. Okay, so again, twice a year, we'll make this event. All the hard work that we're doing at the working group committees will be demonstrated at those events. Okay, so right now, again, this is all subject to change. This is but that's kind of the plan. And again, we've done a lot of research to see what's an effective way to manage these types of projects. And that's kind of where we are at this point. Okay. So again, I apologize for going over. I know we had some issues going forward. Again, it's been very, very positive. I appreciate everyone's input. I look forward to your participation. I look forward to your comments. And again, if we work together and collaborate, I think we're going to make some really, really great things happen. I think what's going to happen is this model that we're doing here, okay, is going to be a model that permeates across the country. And we've seen it happen where everyone's trying to figure out and solve the same problems, and these models are the ways to get these things done. So, if we'll be around. If there's any questions or comments now, we can do it. I know we're running behind. Anyone want to make any comments, thoughts? Great.
Well, I'll just quickly say, I probably not kind of comment you're invited, but I'll make it anyway. I just wanted to thank you all for coming. We're happy to host this and be a partner in this effort, and look forward to working with all of you. I just wanted to quickly mention, as you're leaving, coincidentally, we're having an open house here today for our various healthcare partners across the community. So if any of you are interested in staying and wandering around and seeing the space, you're welcome to. We designed this to be a place that would also facilitate meetings for organizations in the community, so it's available for any of your use. And if you're hungry, you get some free food. If not.
Great. And Randy, thanks again for being so gracious. Okay, we'll be around. If you guys can stay around for the open house, fantastic. Otherwise, again, let me know what your thoughts and comments are, and look forward to seeing everyone here next time.
Body armor on.